My name is Sarah Schmid. I am an assistant professor at the University of Tennessee, and I'm excited to present to you today a stepwise pathophysiologic approach to polyuria and polydipsia. Here is my speaker disclosure. You'll note that I have nothing to disclose. Through the next hour or so that we have together, I'm going to present an 8-step approach to the polyuric and polydipsic patients. We're going to spend the majority of the time focusing on step 3, which is evaluate the urine. And the reasons for this is I want to highlight the pathophysiologic reasons for why polyuria and polydipsia might occur. And so I will go over the 6 criteria that are necessary in health to create concentrated urine and provide examples of how each of these criteria can be altered in disease states. So starting with our first step, is it really polyuria polydipsia? This is where we're going to focus on history. So starting with our definitions, what is polyuria and polydipsia? Normal water intake in a dog or cat is 60 mils per kg per day. So therefore it follows that polydipsia, or too much water intake, is greater than 100 mils per kg per day. Normal urine production in an animal is 1 to 2 mils per kg per hour, which is equivalent to 20 to 45 mils per kg per day. Therefore, polyuria is defined as urine output that exceeds 50 mils per kg per day. Now, when it comes to a clinical patient, these definitions are limited for a number of reasons. For example, water intake can be highly variable. We also know that having a client measure water intake at home can be very challenging, particularly if they have multi-pets within their households. When it comes to urine quantification, it's nearly impossible outside of a hospital setting. And if we were to bring that patient into the hospital to quantify their urine outputs, it might not accurately represent the patient's normal behavior at home. Finally, we know that patients can be clinically polyuric and polydipsic without exceeding the definitions set here on this slide. In addition, it's important to notice that normal water intake can be influenced by a number of things. So environment, for example, we know that dogs thermoregulate through panting, and so can have increased water losses through that, such that in the warmer months, dogs might drink more. We also know that exercise increases water intake. Diet plays a role, whether it's a canned diet or a kibble diet. And feeding frequency can also play a role. So interestingly, there was a study where they took cats fed the same caloric amount, but divided into 2 to 3 times per day. And when they divide into 2 to 3 times per day, they drank more water than when they ate that same caloric amount 1 time a day. So patient comes to you like this corgi here, and the client says, my dog is urinating. Common presenting complaints. And the question really becomes, is this polyuria and polydipsia? Because again, the presenting complaint's often going to be, my dog is urinating a lot, but we have to keep in mind that there are some important quote unquote pretenders that we need to make sure are not at play. So what are our common pretenders of a dog that's urinating a lot or a cat that's urinating a lot? One would be plaquuria, or increased frequency of urination. And this is going to take us on a whole different diagnostic journey than Pupd, because in these scenarios, we're worried about lower urinary tract disease. So things like cystoliths, cystitis, and so on. Plaquuria may be joined by concurrent signs such as hematuria, stranguria, or dysuria. And so the things that we can do to try and identify with the clients whether or not their pet urinating a lot is plaquuria would be asking about the volume and the frequency. Is it a small frequent amount, which would point or dysuria? And so the things that we can do to try and identify with the clients whether or not their pet urinating a lot is plaquuria would be asking about the volume and the frequency. Is it a small frequent amount, which would point us towards plaquuria? And then also asking for some of these other concurrent signs, such as hematuria. Is there any straining or vocalization during urination? Another common pretender we have is urinary incontinence. Again, the client's going to notice a lot of urine potentially in their house, right? And so my dog's urinating a lot. Urinary incontinence being defined as the involuntary passing of urine, like you can see in this ectopic ureter video here. And in these scenarios, we may see concurrent clinical signs such as nocturia, urine scalding, or recurrent UTIs. We may not see any of those. But the questions really to ask when it comes to ruling out this common pretender would be, does the dog seem aware? And also seeing that maybe when the dog's at rest or sleeping, that there's a puddle where they've been sleeping or resting. So asking the client if they've noticed that. And then another thing that can help clue us in on urinary incontinence would be if there's any dribbling of urine. And so it's important to rule out these common pretenders to make sure we're on the right diagnostic pathway of saying this is polyuria polydipsia. And so that leads us to the definition of polyuria, besides the amount of urine being produced, also being defined by the fact that it is conscious voiding of large volumes of urine that is unrelated to lower urinary tract signs, such as straining and plaquuria. So when we're collecting a history in the polyuric and polydipsic patients, a few things we want to clue in on. One is having the client describe the changes in urination to be able to make sure none of those common pretenders are existing, such as what's the volume and the frequency, and does the patient seem aware? We also might ask the client how much water the pet drinks to try and quantify, again, understanding the limitations of doing so. Medication history can be very important. For example, could this patient be on any medications like glucocorticoids or diuretics that are causing increased thirst and urination that maybe the client was not counseled on previously? Another medication that sometimes is overlooked is levothyroxine, used for hypothyroid patients. In some cases, we might oversupplement them and induce hyperthyroidism and see them be Pupd. Not a common thing we see, but have certainly seen it. In addition, we might ask about changes in the environment or potential stressors, as well as touching base on any concurrent systemic signs. How is the patient otherwise feeling in addition to the increased thirst and urination? For example, do they have weight loss in the face of polyphagia that might clue us in on things like diabetes mellitus? In terms of diet history, a few little notes here. So there have been studies that have shown that water intake is influenced by macronutrient distribution. So for example, in cats, they've shown that increased protein content will increase water intake, whereas dogs, increased carbohydrates content increases water intake. We also know that moisture content can play a role. So you can see in this bar graph here, we have water intake on the y-axis, on our x-axis, different diets from canned to dry. And you can see that overall, the heights of the bars, so the total amount of water intake per day, is relatively similar. But the percentage of those bars that are made up by this shaded area, or the black area, is higher in the canned diet, meaning that the canned diet is contributing more to the overall water intake. But overall, the daily water intake is very similar. It's just you're going to see the dog drinking more on a dry diet to compensate the fact that the diet has less moisture content. Sodium content can also influence water intake, and we do use this therapeutically in some of our stone dissolution diets. So here's another graph where we have water intake on the y-axis, and then the salt content is percent dry matter on the x-axis. And so we can see that as we increase our salt content, we are actually getting more water intake overall throughout the day. As I alluded to, a lot of our stone dissolution diets are going to increase water intake to try and help with stone prevention and stone dissolution. Usually they're going to do this by having decreased purines to be able to decrease the amount of urea that's being secreted into the urine, as well as changes in sodium content. And then certainly don't forget that hyperosmolar diets, such as hydrolyzed diets, can contribute to how much a patient is drinking. So after collecting a history, we now need to evaluate the patient. And so if a patient presents like Tucker here in this photo that presented to me, you know, the mystery is not as mysterious about what could be causing the Pupd, because obviously we're looking at this patient thinking, well, this looks like Cushing's disease. However, in a patient that is not so outwardly convincing, it's important to assess the patient's demeanor and behavior. Palpate the bladder. Is it big? Is it small? When we palpate it, is there any urine dribbling that is noted? Do a thorough rectal exam. We'll learn that hypercalcemia can cause polyuria and polydipsia, so checking for those masses. Evaluating for signs of urine scald. And then really looking for evidence of systemic disease. You know, is there lymphadenopathy? Is there splenomegaly? Do we have abdominal pain or abdominal masses on palpation? And then certainly, are there any signs of endocrinopathies, such as hyperadrenal corticism, as seen in Tucker here? Now to the fun part. So step 3, which is evaluating the urine. And I really want to emphasize how helpful a urine-specific gravity can be. And not just us urine-specific gravity, but multiple urine-specific gravities on the same patient. So first we need to talk about what is considered concentrated urine. So we're all familiar with this refractometer. That's usually how we are judging urine concentrating ability in the clinical setting. And with urine-specific gravity, we have essentially 3 terms we use to describe how well concentrated the urine is. So hypersynuria, or well-concentrated urine, isostenuria, and hypostenuria. Now, there are hypostenuria in patients is defined as less than 1008, whereas hyperstenuria differs in the dog and cat because cats have longer loops of Henle. And so you can see then the cat's around 1035, maybe 1040 or above if they're on a dry diet, and a dog 1030. We also have this range that we're not noting here on this from isostenuria to hyperstenuria, which we would call range of minimal concentration. Now, the key thing about these terms for urine-specific gravity is recognizing that they have a prefix, hyper, iso, and hypo, which means we're comparing them to something. What are we comparing the urine to? We are comparing it to plasma, right? Because urine is just an ultrafiltrate of plasma. And so plasma osmolality is going to be around 300. And so when I have iso, meaning the same as, it means that what went in from my plasma filtrate really was not changed a lot by the nephron. And so it is going out the same isostenuria. Whereas if we have actively concentrated that material, it becomes hyperstenuria. And if we actively dilute it, it becomes hypostenuria. So you can imagine with chronic kidney disease where I've lost the nephrons in advanced stages, we're usually seeing isostenuria because of the fact that the nephrons are not able to do anything to that ultrafiltrate that's already coming in plasma at 300. It's really not doing much to manipulate that osmolality. So really the question then becomes, how do I take isostenuria or an osmolality that's similar to plasma and make it concentrated to conserve water? And there are 6 requirements here for normal urine concentration. And we're going to walk through each of these, and I'm going to highlight diseases that are going to interfere with each of these components of urine concentration. So starting with functional nephrons. So we've memorized long ago that when we've lost 2/3 of nephron mass, we are going to see loss of concentrating ability, which is preceding azotemia. So therefore, we need 1/3 of nephron mass to be able to concentrate urine. In dogs, they have around 400,000 nephrons per kidney, and cats 200,000. And so abnormal urine concentration, therefore, can result from loss of functional nephrons. So if we've lost 2/3 of our functional nephron mass, whether it be a permanent loss or a temporary loss, we can see polyuria and polydipsia. And so this is where chronic kidney disease and acute kidney injury come into the picture, recognizing that there are certainly acute kidney injuries that are going to present oliguric and anuric, which is beyond the scope of this talk. What is the next thing we need in addition to having nephrons is we need to have a cortical medullary gradient that is maintained, established and maintained. So here I have put an established cortical medullary gradient behind my nephron. And to understand the cortical medullary gradient, its importance and how it's constructed, we're going to walk through what is happening to renal tubular filtrate when it enters the tubules. So here I'm showing that we have plasma ultrafiltrate entering the tubule at an osmolality of around 300. That is going to go through the proximal tubule, and there's going to be minimal changes on the actual osmolality within the tubular filtrate. And that is not because things aren't being absorbed. In fact, a lot of things, as we all know, are being reabsorbed within the proximal tubule, but it's the fact that it is pretty balanced with water reabsorption. So it's not just solute absorption alone, and therefore the osmolality of the tubular filtrate really doesn't change much. But once we get into our medulla, we have our cortical medullary gradients, and now we have this difference in hyperosmolarity between what's in the interstitium and what's in the tubular filtrate. And by doing this, we're setting up a gradient for water reabsorption. So an important function of the kidney to be able to conserve water. And we're going to be able to have this passive process because we have this gradient established to be able to allow this passively be absorbed without energy. And this is going to go through aquaporin 1 channels. And so as we dive deeper and deeper into the renal medulla, because of countercurrent exchange, I'm simplifying it here, but we are going to be able to continually concentrate that tubular filtrate. Once we get to the bottom of our loop of Henle, we've ran out of space within the medulla. So there's really just a hairpin turn here just to change the direction of fluid. And then we're going to enter our thin ascending loop of Henle. Now here, if this area was permeable to water, I would just undo everything that was done in that descending loop of Henle. And so it is not permeable to water. Instead, it is permeable to sodium chloride. And again, we have a gradient. So this is a passive process. So now we're able to pull out more sodium and chloride in a passive process. And our tubular filtrate, you'll notice, is now decreasing in osmolality. Once we get to the thick ascending loop of Henle, we are now kind of entering near the cortex area. And so we don't have this cortical medullary gradient to be able to passively move solutes. And so this is where active sodium chloride transport is going to occur. So we have our sodium 2-chloride potassium co-transporters. This is where our loop diuretics like furosemide are acting, as well as our sodium chloride symporters, which is where thiazide diuretics are acting within the distal convoluted tubule. And so going through that process with active transport, we are going to make the tubular filtrates hypoosmolar compared to what the plasma is. Which might seem a little bit odd because you're like, well, I thought the whole job of the nephron was to concentrate urine. And you're telling me that we're now 2/3 of the way through the nephron and the urine has actually been diluted compared to what is in the plasma. But it's important to remember that this is a number of important functions for the kidneys. We're reabsorbing water, we're reabsorbing sodium chloride in multiple locations. And the other thing that's important to recognize about this is that I simplified the process in that schematic, right? Because if we're pulling out all this water, eventually we're going to dilute out the cortical medullary gradient, and we need to figure out how to establish what is making that pull. And so the cortical medullary gradient is maintained by 2 major solutes, sodium and urea, and they are absorbed in kind of respective areas within the nephron. So majority of sodium is actually happening in the proximal tubule, but urea is going to happen there as well. And you can see some other sites beyond those that we just talked about where sodium is being reabsorbed. And by doing that, we're able to now have the pull to be able to pull water out in the descending loop of Henle. So just to dive a little bit more into urea transporters. So 100% of urea that is filtered through the glomerulus into the renal tubules. And then approximately half of it is going to be reabsorbed into the proximal tubule, or reabsorbed from the proximal tubule. An equal amount of urea is then secreted through urea transporter A2 into the thin loop of Henle. And then finally, it is going to be reabsorbed, about a half of it again. It's going to be reabsorbed in the collecting duct using urea transporter A3, etc. And what's happening with this is that we're really creating this cycle of urea that's going to be being reabsorbed and secreted to be able to establish the cortical medullary gradient. And interestingly, when we're going to talk a little bit later about antidiuretic hormone or vasopressin, that is something that's going to be released when our body is saying, hey, I need to conserve more free water. And so our reabsorptive urea transporters are going to be upregulated in the presence of antidiuretic hormone. So it's going to help us better concentrate our urine. And so increasing the concentrating ability by improving the amount of urea that's being put into that cortical medullary gradient or the interstitium. So you might say, well, this physiology is great, but what does it matter to me? And so the clinical correlate here is talking about prerenal azotemia. So BUN to creatinine ratios on blood work, normally we expect them to be less than 30, but there's some instances where our BUN is going to exceed creatinine ratio of 30. Certainly, kind of the routine things we think about as well, is there somehow more urea in the body? So thinking about urea being a breakdown product of being what the liver makes out of ammonia and protein breakdown, could say, well, maybe we have a high protein diet, or we have GI bleeding, upper GI bleeding that's contributing to a bunch of protein, a big protein bolus going into the upper GI tract. Or maybe we have a reason that our creatinine is lower than normal. So like a really old CKD cat that has a lot of muscle wasting, they have less creatinine to contribute. And so their azotemia is going to have a higher BUN to creatinine. However, the purpose of kind of explaining our urea transporters previously was really to reflect the fact that in prerenal azotemia, so from dehydration, because of that upregulation of ADH or vasopressin, we can see an increase in the BUN to creatinine ratio. All right, so I have really simplified the cortical medullary gradients and how it is established. So now we're going to backtrack a little bit just to explain that. And so the renal medulla takes time to become hyperosmotic. So first of all, we need to assume, as in this picture, is that our loop is filled with tubular filtrate at a concentration of 300 milliosmoles per liter, which is essentially plasma, right? And so how are we going to then establish a gradient? Well, the first thing is, as we've shown in the previous kind of schematics, is that those active pumps within our thick ascending limb of the loop of Henle, and our distal convoluted tubule, are going to actively be causing sodium to be reabsorbed. And so through that, we're now going to get a bunch of sodium pumped into our interstitium to make it more concentrated within the medullary interstitium. With that, now water can follow the gradient. And so we can pull out water of our descending loop of Henle. And so now the concentration with those tubular filtrate there is going to become 400. And that's going to move around the loop of Henle to make what's going on our ascending limb of the loop of Henle more concentrated. And then we're going to repeat the process of those active sodium potassium chloride pumps to result in more and more sodium absorption. And so this process is going to repeat itself over and over until we essentially establish our cortical medullary gradients. And so the loop of Henle is often referred to, because of this reason, because of what I just showed here, is often referred to as the countercurrents multiplier. Again, why does this matter? Well, there's some clinical implications to establishing a cortical medullary gradient. The first thing is that when we hang a bag of fluids and we're giving IV fluids to a patient, we are inducing medullary washouts because they don't really have a need right now to concentrate their urine. And so if we abruptly discontinue those IV fluids, we're leaving the kidney in a state of medullary washout, which could be harmful if a patient has an underlying kind of kidney injury, et cetera. And so it's really important, when possible, to wean our IV fluids in patients. So don't be mean, wean. And then another implication that comes into play for this talk specifically is that when we have a patient that has primary polydipsia, so is drinking too much, they can actually, after 3 days of drinking more water than they need, induce medullary washout within their kidney. And so then when you go, and so through that process, they're going to have impaired reabsorption of sodium chloride and urea. And so when you go to say, well, this patient isn't concentrating their urine, it's going to make you think that they are an obligate polyuric patient, when in fact they do not have obligate polyuria. It's just that they have induced medullary washout. And so we need to slowly reestablish that gradient by pulling back on the amount of water they're getting in a safe manner to be able to prove to ourselves that, yes, they are capable of concentrating urine. So thinking about the medullary gradients, what can go wrong when we have abnormal urine concentration? This is where we talk about medullary washout. So medullary washout is the loss of the cortical medullary gradient. When we think about what makes up our cortical medullary gradient, it follows that if I have a case of hyponatremia or low urea, we can induce medullary washout. So with hyponatremia, thinking about diseases like hypoadrenochlorosis or Addison's disease. Low BUN can be caused by liver dysfunction, so maybe a puppy that's coming with a congenital poor systemic shunt, or a dog that has developed end-stage liver failure. This is also how a lot of our stone dissolution diets, being purine restricted, are going to induce polyuria and polydipsia. Decreased protein intake similarly, and then in some young animals, we can also have this be a cause of why their ability to concentrate their urine is not as it would be once they become adult. Other things to consider in this is not just the solutes that are in the medullary gradient, but also how we are establishing that medullary gradient. So if we had tubular filtrate that's moving too quickly to establish a gradient, we can have medullary washout and polyuria and polydipsia. And this is a way in which hyperthyroidism, among other mechanisms, can cause PUPD. We also can see things that interfere with tubular cell function, right? So as we went over how to establish the cortical medullary gradients, we need to have active transporters within our thick ascending limb loop of Henle to be able to absorb that sodium and establish a gradient. And so if we're interfering with that with an acute kidney injury, for example, certain drugs, diuretics, etc., we're not going to be able to concentrate the urine. Prototheca, interestingly, has been identified as causing PUPD in patients. There's a couple case kind of series and reports out there, and we don't quite understand the mechanism of it. It was proposed in a couple studies, given the fact that they can actually document the organisms within the urine, that they are inhibiting or interfering with possible tubular cell function and countercurrent exchange. However, there's several other mechanisms that could be at play. So key points I want to bring here is, I guess, kind of a little bit of a side, is that when we think about nephron loss and our cortical medullary gradient and how we're making hypostenuria once we reach kind of the distal convoluted tubule, is that the loss of concentrating ability of the nephron is going to precede the loss of diluting ability. So what does that mean clinically? It means that, I know this is a common misconception, but it means that hypostenuria cannot rule out renal azotemia. So oftentimes we want to think that, but it actually cannot, because of the fact that the nephron is still going to maintain the ability to dilute a little bit longer than concentrating ability. So in early CKD, we could see this. However, I want to emphasize this is uncommon. So thinking about kind of approaching the day-to-day case, it's not very common that we're going to see hypostenuria with CKD. And that's probably because of the obligatory solute load excretion leading to a solute diuresis and therefore having isostenuria. So it's not common we see this, but I just want to debunk the common misconception that hypostenuria can rule out renal azotemia. All right, so we have built our nephron on top of our cortical medullary gradient, which is all great. The next thing we need to be able to concentrate urine is to have an appropriate renal tubular filtrate. So as we went through the cortical medullary gradient, you can see how there's a lot of gradients being established to be able to move water and solutes in a passive manner. If we were to dump a solute into our renal tubular filtrate that is hyperosmolar, we're suddenly not going to be able to have that gradient. And in fact, we might even reverse the gradient such that we're getting water getting pulled into our renal tubular filtrate. So this is what we call osmotic diuresis when we're talking about abnormal urine concentration here. So osmotic diuresis, really the big thing that we're thinking about here is glucoseuria. So recall that 100% of our glucose is going to be filtered freely through the glomerulus. But the reason why in health it's not going to end up in the urine is that the proximal tubular cells, the powerhouses that they are going to reabsorb that glucose load. And we have a threshold that's set here, saying basically what concentration within the periphery, within the blood, are dogs and cats capable, their proximal tubular cells capable of reabsorbing that extra glucose. And in dogs, it's around 180. So once we exceed 180 milligrams per deciliter within our plasma, we're going to see spillover in the urine because those proximal tubular cells cannot keep up. And then in cats, it's greater than 280. And so if we are exceeding these thresholds, again, what the proximal tubular cell can do, we are going to see diabetes, or we can see glucosuria in the case of diabetes mellitus. Recognizing that diabetes mellitus requires it to be persistent glucosuria and hyperglycemia. However, there are scenarios where that proximal tubular cells are not functioning, where they're damaged, and that's when we get things like renal glucosuria. And so things, in terms of renal glucosuria, we think about primary renal glucosuria, which is Fanconi syndrome. We've seen it identified in the Basenji, of course, and the Norwegian elk hound, Irish wolfhounds. We also can see acquired renal tubulopathies, whether they be from jerky treats. There's been a number of studies that have looked at, particularly in Labradors, at copper-associated hepatitis, so Wilson's disease in people. They actually show that you're not only getting copper buildup within your hepatocytes, but also within your proximal tubular cells. And in people, it can be reversible with using penicillamine. And so that can also cause glucosuria and proteinuria. And then certainly there's a number of toxins and drugs that can influence, affect the proximal tubule cells, causing glucosuria, and therefore PUPD from osmotic diuresis. The other player that can change osmolality would be mannitol. Quick little side here. So this is a 2022 paper that came out looking at the outcome of acquired Fanconi syndrome in 30 dogs that had ingested jerky treats. Not necessarily new information here in terms of clinical signs, but you can see that a number of them were polyuric and polydipsic. Not as many of them were actually azotemic when we look at their blood work changes. And the things that I kind of want to recognize from this study is that compared to kind of previous reports, they actually had a little bit of a better outcome in these patients, with 22 out of 28 of them having resolution in their clinical signs. Now, that took on average around 11 weeks, ranged from 0.3 to 52 weeks. Interestingly, despite their clinical signs taking about 11 weeks to resolve, the glucosuria was actually resolving a lot quicker, so within 6.5 weeks. I'm not really sure why that might be, that they still have persistent polyuria and polydipsia, but just something interesting to note. All right, so where did we leave off within our nephron? So we left off with the distal convoluted tubule, where we have hypostenuria. And that might be fine to urinate out dilute urine if we have an extra amount of water in the patient. So this is where it comes into play. What is appropriate for that patient? So urine-specific gravity should always be interpreted in light of what the patient looks like, right? Like if a patient has hypostenuria and is dehydrated on a physical exam, that is inappropriate. If a patient's well hydrated, drinking a lot of water, then they're drinking more than they need, then of course their urine is going to be hypostenuric. So it's always important to interpret it in light of the patient. But in a patient that's, for example, in a very dehydrated state, we would expect that they would be able to bring their urine to be concentrated to help conserve some of that water. So what is happening here in the distal parts of the nephron? That brings us to steps 4 and 5 for our 6 requirements. So step 4 being that we now need the body, right? Because this is all about what is appropriate for that patient. We now need the rest of the body to communicate to the nephrons that have been doing their job to say, hey, I actually need more or less water right now. And so that's going to involve the production of antidiuretic hormone, also known as vasopressin. And that is going to happen from a number of reasons, including osmoreceptors in the brain, resulting in the secretion and the production of ADH from the hypothalamus, which is stored in the posterior pituitary and then released at the appropriate times. So what is stimulating antidiuretic hormone to be released? Obviously, plasma osmolality, right? So we want to maintain our plasma osmolality so all the cells and all the exchanges are all perfect around 300 milliosmoles. And so osmoreceptors receptors are going to basically be tasting the plasma to figure out whether or not it's appropriate. So in this figure here, you can see in a hyperosmolar state that we're going to have these neurons, supraventricular neurons, et cetera, within the hypothalamus are going to shrink when there's a very hyperosmolar environment, which is going to result in vasopressin or ADH release, therefore increasing thirst and urine constrainability, et cetera. Whereas when we're in a hypoosmolar environment, those cells are going to swell, and that's going to turn off vasopressin release because we actually need to get rid of that extra free water. Other things that are going to contribute is going to be our arterial blood pressure as well as blood volume, and that's going to be perceived by baroreceptors. And then there's a number of other stimuli that have been identified. For example, it's been shown that nausea or vomiting can increase ADH production by 100-fold. There's also a number of drugs, more so studied within the human literature, that can influence antidiuretic hormone production. So when we have abnormal urine concentrating, what is happening with ADH production? When we don't have ADH production, that is known as central diabetes insipidus. So now we're getting into ADH or vasopressin, we're talking about diabetes insipidus. So the key point here is that ADH release from the pituitary is necessary for the reabsorption of free water from our renal tubules. So in order to absorb that free water from the renal tubules, we need ADH production. If we aren't making ADH, our urine-specific gravity with complete central diabetes insipidus and no ADH to be found is going to be less than 1006. Now, there is partial central diabetes insipidus where we can have USGs that are going up to 1015 or so, but they're usually less, still under 1015, 1017. And so I just want to emphasize here that isostinuria, that 1008 to 1012 range, does not rule out partial central diabetes insipidus. So why might we develop, or why might our patients develop central diabetes insipidus? Most of the time, this is going to be an idiopathic process. However, there are a host of other things that can cause central diabetes insipidus. So from head traumas to masses to inflammation. There was a case report in a dog that had a transient central diabetes insipidus after a cardiac arrest that was treated and then resolved and no longer required medications. We also know that pheochromocytomas are perceived to be causing polyuria polydipsia, at least in part, because catecholamines are going to influence ADH production within the hypothalamus. This is a dog that I saw back in my residency that had narcolepsy from this pituitary mass, and actually later ended up developing a central diabetes insipidus. As you can imagine, hypothalamus pituitary being pretty effaced at this point. All right, so just because we make antidiuretic hormone and put it into the bloodstream to go do its thing, it's a hormone, right? It's going to go to a distant site, doesn't mean that it is acting on its distant receptor. So we also need to have a response to antidiuretic hormone at the level of the renal tubule. So antidiuretic hormone is going to be acting on vasopressin 2 receptors, or V2 receptors, and these are living in the distal tubules, the collecting ducts, and the collecting tubules. And when ADH interacts with its vasopressin receptor, we are going to see an increase in cyclic AMP, and that is going to lead to activation of protein kinase A. It's going to lead to protein phosphorylation, and ultimately the translocation of proteins that are living in the cytoplasm to move to the luminal side of cell membranes. And in this case, the protein we're talking about is aquaporin 2 channels. So aquaporin 2 channels are going to be the channels that are going to allow water to be reabsorbed, to concentrate the tubular filtrates and concentrate the urine. And then once that ADH goes away, we don't have anti-RB2 receptors, those aquaporin channels are going to be shuttled back into the cell cytoplasm. There are also aquaporin 3 and aquaporin 4 channels that are not under the influence of ADH, at least to our understanding currently, that are inserted here on the basolateral side of the cell to help pull that water all the way through the tubular cell. And then we had already learned aquaporin 1 channels were in the descending loop of Henle. So putting that all together, again, we've ended at the distal convoluted tubule with tubular filtrate that is hypostenure, or that is more dilute. And so we have ADH to act on vasopressin 2 receptors, result in the insertion of aquaporin channels. That's going to lead to reabsorption of water. So we ultimately can concentrate tubular filtrate and have hypersynuria. So our key points here are that a response to ADH at the level of the nephron is necessary for the reabsorption of water from renal tubules. And with CDI and ADH, or excuse me, with central diabetes insipidus and nephrogenic diabetes insipidus, our urine specific gravity can be less than 1008, but it can be anywhere from hypostenuric to minimally concentrated. And so we have abnormal urine concentration, and are thinking about mechanisms by which we're not having a response to ADH. That lack of response to ADH is known as nephrogenic diabetes insipidus. And nephrogenic diabetes insipidus can occur either as a primary or secondary process. Primary nephrogenic diabetes insipidus is extremely rare. So in people, there are 2 congenital forms of nephrogenic diabetes insipidus that have been described. And in approximately 90 to 95% of people, the disorder is actually an X-linked mutation in the aquaporin channels. And so, interestingly, when we look at the kind of case reports that have been presented in veterinary medicine, there are some similarities with male dogs being affected. Whether or not that's X-linked has yet to be determined. But there was in this kind of case report looking at a family of huskies. The female puppy was found to be a carrier, and then 3 out of the 4 male dogs were found to be clinical. And then other dogs that have been identified, including Boston Terrier, Elkhound, and then it has also been reported in a young thoroughbred colt. So again, male linked potentially there. Has not yet been documented in cats. So most of the time when we're talking about nephrogenic diabetes insipidus, we're really talking about a secondary nephrogenic diabetes insipidus. So what is causing secondary nephrogenic diabetes insipidus? And here we're thinking about things that are interfering with the ability for ADH to interact with its V2 receptor or that cyclic AMP response, et cetera, happening within kind of the cellular process of getting those aquaporin channels to translocate to the luminal membrane. So our big one here is going to be hypercortisolemia, whether it be endogenous or exogenous. So endogenous in the case of hyperadrenal corticism, or if we're giving corticosteroids. It's the big reason why we're going to see polyuria and polydipsia with our prednisone use. Another example would be E. coli endotoxin. So this is a reason why pyometras can be associated with polyuria and polydipsia, prostatitis. You could have pyelonephritis also cause PUPD through this way, in addition to other mechanisms of disrupting cortical medullary gradients, etc. Hypercalcemia is another big one here that can cause a secondary nephrogenic diabetes insipidus. So making sure if you're seeing that hypocynuria, going through differentials of what could lead, making sure there's not hypercalcemia, and then going down that journey of what are all the causes of hypercalcemia using the mnemonic of your choice. Leptospirosis, interestingly, has been postulated, at least in one case report, to be causing a secondary nephrogenic diabetes insipidus. And an interesting thing about leptospirosis is that we can see PUPD without azotemia. So it is still something I'm considering in a polydipsic patient, even when they're not azotemic. Other ones would be hypokalemia. So having low potassium can alter the way that these tubular cells are functioning. And then another kind of zebra is leiomyosarcoma. There's a report of a secondary nephrogenic diabetes insipidus caused by a intestinal leiomyosarcoma. So our key points here, now that we've kind of talked about the diabetes insipidus, so lack of making ADH or a lack of response to ADH, key points here is that I want to say is that hyposynuria is a beautiful thing. I love when I can find hyposynuria on a patient that's presenting for polyuria and polydipsia. And the reason for that is that if the USG is less than 1008, the problem is really most likely due to one of three things. It's either due to the fact that we don't have ADH, so a central diabetes insipidus, we aren't responding appropriately to that ADH at the level of the tubules, or a nephrogenic diabetes insipidus, or the patient is simply exceeding the amount of water they need and drinking too much water, so a primary polydipsia. Now, I've alluded to before that it is possible in early CKD to see hyposynuria, so don't forget that little tidbit. But most commonly, when we're seeing hyposynuria, these are the things that are going through my mind, and I'm going to tailor my kind of what diagnostics I'm starting out with first based on these top differentials. Now, we've walked through kind of how urine's being concentrated, but we need to remember that urine's not going to be concentrated if there's not an appropriate amount of water intake, right? So if water intake is exceeding the amount that that patient needs, we're going to see polyuria and polydipsia, and that mechanism is going to be way different than the other 5 requirements we've talked through. And this is when we talk about primary or psychogenic polydipsia. It is important that we rule out every other differential diagnosis. This Pupd is a true polydipsia that is creating a polyurian response to get rid of that excess water that's being consumed. And things we might think about in this category would be behavioral things. Certainly I've seen it with a number of dogs with chronic gastrointestinal disease, like chronic enteropathies, has been reported with hepatic encephalopathies, splenomegaly, list goes on. Diagnosis, if you're going to read in the kind of gold standard textbook, would be doing a modified water deprivation test. As we talked about establishing a cortical medullary gradient earlier, we talked about how when you have primary polydipsia, you can induce medullary washout. And so after 3 days of just drinking more water than that patient needs, they could end up looking like an obligate polyuric patient, even when they're not. So we have to use caution. And treatment is usually going to be treating the primary underlying disease, the thing that's causing pain or behavioral issues, and maybe modifying the behavior. So putting it all together, looking at these are the 6 things we need to be able to concentrate urine normally, and thinking about what could go wrong with each of these 6 criteria. So if I don't have functional nephrons, thinking about kidney disease. If we're not maintaining a cortical medullary gradient, that'd be medullary washout. If the tubular filtrate is not an appropriate osmolality, that's talking about osmotic diuresis. If we're not making ADH, that's central diabetes insipidus. Not responding would be a nephrogenic diabetes insipidus. And then, of course, we need to have an appropriate amount of water intake. And if we aren't doing that, that would be a primary polydipsia that's driving a secondary polyuria. And so here's a chart that I've included in the proceedings to kind of show how I put this kind of together in my mind when I'm approaching a patient with polyuria and polydipsia, and kind of leaning in on what the urine specific gravity is doing. So you'll notice that when we're getting, again, to hyposynuria, we're really moving down to the bottom half of this chart, thinking about things that are affecting ADH production or response, or primary polydipsia. And so by kind of looking at what my urine specific gravity is doing, I can try and tailor myself to think, well, which area do I think is most likely in this patient? Now, back to kind of the steps, right? We went through a whole kind of aside about talking about why urine might not be concentrated, but really our goal with this step 3 was to evaluate the urine. And one of the most important things is going to be looking at the urine specific gravity. And I want to emphasize, don't just base it off of one urine specific gravity. To me, the most helpful thing in a polyuric polydipsic patient is to get multiple urine samples on different times and different days. These are some urine samples from a patient you can see, and there's quite a bit of variability here just from this one patient that's presenting with polyuria and polydipsia. And reasons for this is that urine specific gravity can vary considerably in healthy animals. Even in first morning samples, we've seen that first morning samples are not always the most concentrated. If you're getting a bunch of these urine samples, like in this patient here, and you see that one of these is greater than 1035, you can probably lean into this is likely a primary polydipsia case and save the clients a lot of time and money on expensive diagnostics. If we're seeing persistent, keyword persistent here, hypostenuria, we're going to lean into things like nephrogenic or central diabetes insipidus, keeping in mind that primary polydipsia is possible, but again, by getting more samples, we're hoping that we're eventually going to catch when that patient is not drinking as much water and therefore has a more concentrated urine sample. Given what we've talked about with central diabetes insipidus, if we have a single urine-specific gravity greater than 1020, we can comfortably rule out central diabetes insipidus and shouldn't be doing desmopressin trials, et cetera, in those patients. If the USG is very static, particularly when it's in the isoscenuric to minimally concentrated range, we're thinking about chronic kidney disease. Reason for that being that a lot of endocrinopathies are associated with Pupd. And when you think about endocrinopathies, they're hormone driven, right? So hormones are going to fluctuate throughout the day, whereas the number of nephrons you have in a chronic kidney disease are not going to change that abruptly. And so usually the urine-specific gravity is going to hang out around the same area. So again, emphasizing how helpful it can be getting multiple urine samples. So what are we going to do with those urine samples besides the urine-specific gravity? It's going to be helpful to look for things like bacteria, pyuria, looking at glucoseuria, and if we see that glucoseuria, then grabbing a peripheral blood glucose and be able to compare that to what the renal threshold is in a dog and a cat. And if it is exceeding the renal threshold, that would fit with the diabetes mellitus, versus if it is under, again, this would have to be a persistent exceeding the renal threshold, persistent glucoseuria and persistent hyperglycemia to diagnose diabetes mellitus, versus if it's less than that, we might be thinking about a renal glucoseuria. Urine culture is also very helpful. We know that pyelonephritis can cause Pupd. Obviously, a single negative urine culture is not going to rule out pyelonephritis. And then certainly we can see secondary bacterial infections from patients that are polyuric. All right, so we spent a lot of time in the first three steps, and we're going to fly through kind of the last few steps here pretty quickly. But moving on to step 4, which is looking at the minimum database. It's really going to be based on thinking about the mechanisms by which Pupd can occur. So our complete blood count, it's really, we're looking at ruling out systemic diseases. So looking at hematocrit, you might see erythrocytosis simply because of a consequence of an obligate polyuria where that patient is losing free water and hemoconcentrated. But also keeping in mind our zebra is that polycythemia vera can cause polyuria and polydipsia. Evaluating the leukogram, so looking for signs of a systemic inflammatory disease, looking for evidence of a stress leukogram, and if it's not there, thinking about things like Addison's disease. Platelets, thinking about with thrombocytosis, maybe pushing us towards, another puzzle piece to say, is there possible hyperadrenal or thinking about things like iron deficiency associated with GI bleeding and GI pain causing a primary polydipsia. For the chemistry panel, thinking about kind of what electrolytes are playing a role in urine concentrating ability, as well as maybe causing a secondary nephrogenic diabetes insipidus. I'm going to pay specific attention to the calcium, the potassium, and the sodium. Look for evidence of azotemia. Look at our glucose in the case of diabetes mellitus versus primary renal glucoseuria. Liver enzymes more so helpful when we're thinking about another puzzle piece to kind of clue me in on maybe an endocrinopathy is occurring. But when it comes to liver disease causing Pupd, typically it's going to be from liver dysfunction. So making sure, even in the absence of seeing signs of leakage enzymes, that my liver is functioning well by laying eyes on those synthetic parameters, particularly that urea, knowing that urea plays an important role in the glucomedullary gradient. So based on what's common, our next step is going to be to screen for endocrinopathies. So common is common. So based on our signalment, our history, and the results of our minimum database, we're going to screen patients for endocrinopathies in a cat and an adult cat, thinking about screening for hyperthyroidism. In dogs, screening for hyperadrenocorticism. And certainly in both of them, diabetes mellitus is another common cause of Pupd. Typically, you're going to be picking that up from the glucoseuria on your step 3, looking at the urine. Step 6 is going to be evaluating for early chronic kidney disease. We're talking about early because these are patients that are not yet azotemic. And this is because in addition to diabetes mellitus and hyperthyroidism and hyperthyroidism, chronic kidney disease is one of our top 3 in dogs and cats for Pupd. And so it's important to note that loss of urine concentrating ability will occur prior to azotemia, right? We lose 2/3 of our nephron mass, we get loss of concentrating ability, and then once we lose 75%, we're seeing that azotemia. This is far more common in dogs. Cats are a little bit weird, as we all know, and so cats can become azotemic and still be able to concentrate their urine. So things that are cluing me in on thinking about, could this be an early chronic kidney disease, would be if they're isostenuric, it's minimally concentrated. And again, emphasizing if the urine-specific gravity is static, that's maybe cluing me in a little bit more because it's not, number of nephrons aren't really changing, functional nephrons, whereas with a endocrinopathy, that can be changing from time to time, as well as behavior can change from time to time. So if there are concerns for early chronic kidney disease, how do I prove it? Several years ago, SDMA came out and we're all very hopeful. I think the studies had shown promise because it works really well on a population basis, but it's been my personal experience that it's really challenging to use this in Pupd patients to rule in or out CKD, unless we're trending individual patients prior to when they got their Pupd. So most of the time, what's going to be the best way to evaluate for early chronic kidney disease is going to be doing some sort of GFR study. Endogenous creatinine GFR studies are quite feasible to be able to perform in a practice, and so that would be a good starting place. All right, so step 7. Now we're going to kind of evaluate for more systemic diseases. Now I want to emphasize these steps I'm presenting to you are obviously going to vary depending on what you're seeing in your physical exam, right? So if your physical exam or the patient, how sick the patient is, and the history, if there's lots of systemic signs, are maybe going to prompt these steps to come earlier, but just kind of presenting in the patient that's otherwise well in Pupd, this would be kind of a step 7. But we might do this earlier, and this would be things like abdominal and thoracic imaging. So looking for masses, particularly if there's abdominal pain, seeing what's going on there, other systemic signs. We might be considering brain MRIs, et cetera, to be able to evaluate for masses or things, particularly in patients that have behavior changes, or we're working up a patient with a suspect primary polydipsia that has other kind of behavioral changes. Recommend doing an ionized calcium, even if the total calcium is normal. Liver function tests can come into play here. So doing a bile acid stimulation test, looking at pneumonia if you have that ability in your practice. And then this is also where we consider things like leptospirosis serology, remembering that not all leptospirosis patients are azotemic. They could just be Pupd. So doing convalescent serology and or PCR testing. All right, so final step, step 8, is going to be looking for central diabetes insipidus versus primary nephrogenic diabetes insipidus. So when do we kind of consider testing for CDI versus NDI versus primary polydipsia? Really our test of choice here is going to be, by test of choice, the gold standard test, I should say, is a modified water deprivation test. But it's my belief that that's rarely indicated and it's not risk-free. And so we're going to talk about some alternatives. Other things we consider doing for testing for these is a desmopressin, so synthetic vasopressin trial. When we're considering these things, we want to make sure that all other causes have been ruled out. And so just briefly touching on the modified water deprivation test, again, emphasizing this is rarely indicated, but it's important that before we do this, that we rule out all other possible causes of polyuria and polydipsia, keeping in mind that this modified water deprivation test is really to be able to determine primary nephrogenic diabetes insipidus. So it's important to rule out those associated secondary causes of nephrogenic diabetes insipidus. For example, dogs with hyperadrenal can respond to a desmopressin trial. We also want to make sure when we're doing a modified water deprivation test that we never perform it in an animal that either has pre-existing renal azotemia, is obviously dehydrated on physical exam, right? Like they're losing free water, or they're hypernatremic. As that can be very dangerous. And also want to emphasize that any modified water deprivation test is dangerous if we are not instituting proper monitoring. So what does the modified water deprivation test look like? It looks like 3 phases. So phase 1 would be minimizing the effects of medullary washout. So going back to the fact that these primary polydipsia patients can induce medullary washout in themselves. And so we want to determine the unrestricted water intake level and then do a slow water restriction from that initial value by reducing it about 10% every day over 3 to 5 days to be able to allow that patient to reestablish their cortical medullary gradient. Phase 2 is going to be the actual water deprivation. This is going to involve very close monitoring, bringing that patient into the hospital, having a urinary catheter in to be able to monitor urine output, urine specific gravities, weight. And we're going to do that water deprivation until they reach an endpoint of 3%, maybe 5%, or that they have successfully concentrated their urine. And then phase 3 would be a response to synthetic vasopressin or desmopressin. And so this is just to kind of show you some examples that are taken from the canine and feline endocrinology textbook. And so you can see a normal versus central diabetes insipidus versus nephrogenic diabetes insipidus patient here. We're looking at urine osmolality on the y-axis and time on the x. And so you can see in a normal patient, it can take a little bit for them to reach their endpoint, right? Because they're not going to be losing their weight because they're able to concentrate their urine. And so we're really waiting for their urine to get concentrated. And it can take several hours for that to happen. So this can be a long test. However, when we have diabetes insipidus, I want you to note how quickly these patients are reaching their endpoint, which in this case is 5% of body weight loss. It's quite quickly. And if that goes unnoticed, it could be very dangerous. And then to be able to differentiate, looking at central versus nephrogenic diabetes insipidus, we're going to be looking at giving desmopressin, which is not going to have an influence on a normal dog. And when we think about central versus nephrogenic diabetes insipidus, with central, if we give that synthetic version, it's going to have a response versus a primary nephrogenic diabetes insipidus would not. Keeping in mind that we still need to rule out the secondary nephrogenic diabetes insipidus because some of them can variably respond like Cushing's disease. All right, so we went through that and I said it's rarely indicated. So I want to propose an alternative approach. And this is typically what I'm doing with my Pupd patients. The first step is evaluate as many urine specific gravities as you can, if I haven't already emphasized that point. So different times, different days. Using a refractometer is quite cheap. And so see what those values are. If a single urine specific gravity is exceeding 1030 or 1035 in a cat without glucosuria, remembering that glucose can falsely increase our USG a little bit, we're probably looking at a primary polydipsia. And we can kind of focus then on behavioral modification or looking for other behavior changes in MRI, et cetera, if needed. If the urine specific gravity is consistently hypostenuric, then I would be thinking about a desmopressin trial. Now, we kind of skipped over the sodium concentration because I wanted to talk about it a little bit here. Is the patient's plasma sodium can really help you out in determining next steps in this scenario. So, thinking about the value of sodium, if we have a high sodium or a hypernatremia in a Pupd patient, it is suggesting that there's free water loss, right? There's loss of free water. So we're thinking about something wrong with ADH. So either a central diabetes insipidus or a nephrogenic diabetes insipidus. Obviously, there's other exceptions like hyperaldosteronism, which can cause Pupd, but causing it through different mechanisms, usually with associated renal disease. Whereas on the flip side, if we think about a low sodium or a hyponatremia, there's a couple things that could be happening. So when we have hyponatremia, the first thing is going to say, well, is this a pseudo hyponatremia? Meaning, is there hyperlipidemia, hyperproteinemia that is altering the sodium readouts? Or could there be translocation? So thinking about hyperglycemia, where we're having translocation of water into the intravascular space, given that hyperglycemia. But when it comes to a patient's Pupd and we're able to evaluate and find out that they are hyponatremic, we can rule out a lot of these causes by simply inspecting what the serum looks like, looking at a biochemistry to see if they have any hyperglycemia, and looking at the history. So then we'll be left with a hypoosmolar hyponatremia. So a hyponatremia is hypoosmolar. There's really one of two things happening. Either we're having a problem getting rid of free water. So maybe we're hypovolemic and not able to support the kidneys and getting rid of all that extra water, or syndrome of inappropriate ADH secretion, renal failure, certain drugs, solutes being decreased that we can't have our kidneys pumps function properly, or we're having water intake that exceeds capacity. And so then the question becomes, well, why does my patient have free water? And that's when we focus on things like primary polydipsia. So hyponatremia makes me think about things of, is there some reason that this patient is consuming more water than they need? So thinking about things like hepatic encephalopathy, Cushing's, we're usually thinking of a secondary nephrogenic diabetes insipidus, but certainly if they had a pituitary macroadenoma, this could be at play as well. Whether there's obsessive or behavioral changes, gastrointestinal disease. This is the mechanism or primary polydipsia by which splenomegaly has been associated with Pupd, thought to be stretch of the splenic capsule causing discomfort and then increased water intake. Other alternative explanations could be the etiology of that splenomegaly. So for example, is there lymphoma and a perineoplastic hypercalcemia, et cetera, associated with that? All right, so thinking about our sodium, the question really becomes, should I do a desmopressin trial? And our sodium is going to help us out. So if our sodium is high within the reference interval or high, we're thinking there's free water loss. And so a desmopressin trial might be helpful. If I give desmopressin, again, this is after I've ruled out everything else. If I give desmopressin and there is a response, I'm thinking central diabetes insipidus. If there is no response, thinking nephrogenic diabetes insipidus. On the flip side, if I have a hyponatremia or a sodium that is the low end of the reference interval, I'm thinking, okay, water intake in this scenario is exceeding the excretion capacity. And so I want to consider a primary polydipsia. And I want to emphasize, never, ever do a desmopressin trial in a patient that has hyponatremia. Because if you think about it, if I give them more ADH, there is a potential that they can even better reabsorb that free water and drive that sodium further down. And you can see lots of negative consequences, seizures, etc. So when it comes to a desmopressin trial, it's helpful to start off by getting a baseline water consumption, giving synthetic vasopressin or desmopressin for 5 to 7 days. We have tablet forms or we have the intranasal prep. And I'm personally going to usually start with the oral form just because I know exactly how much they're getting, but both are very effective. I usually start at every 8 hours for my trial and then back down to try and save on costs if the patient will tolerate it after I confirm that they're a responder. It's important to allow free access to water during the trial. How do we determine if there's a response? We're going to need to monitor their water intake, take urine samples on days 3 to 7 of the trial for urine-specific gravity. And by interpreting those, we can see that central diabetes insipidus will have an increase in water intake and urine-specific gravity by greater than 50%. Whereas with nephrogenic, we're not going to see a change, nor will we see with primary polydipsia. All right, so that was a whirlwind, but hopefully it helps kind of give you guys a starting ground on how to approach these polyuric and polydipsic patients. Conclusions are that common is common. So the top 3 differentials for Pupd in a dog are diabetes mellitus, CKD, and hyperadrenochromosism. In a cat, diabetes mellitus, CKD, and hyperthyroidism. And it can be helpful to approach Pupd in a stepwise fashion, keeping in mind that if your physical exam or your history is showing something systemic, you're probably going to proceed with more diagnostics like imaging earlier in the workup. With that, thank you for attending this on-demand session. You are welcome to email any questions you have. My email is listed here. Even if your question is where to get awesome kidney cookie cutters, like the ones used here. But I appreciate your attention and hope you found it helpful.